Really quickly, I wanted to bring up another point with this last case. This is a case of patient with prostate cancer, metastatic disease, coming in. Unlike the first case, who's neurologically intact, this patient is 2 out of 5 in their legs. Basically just twitches in the toes, maybe some rotation of the hips and the legs. Here, there's T11, severe pathological fracture. You can just tell here, this is a T2 image, does not look good there, right? A lot of cord compression, retropulsion of the bone that's there. The axial shows that spinal cord is clearly deformed, distorted. This is all tumor involving that area, right? You can tell the patient's pretty thin. This is the skin, subcutaneous tissue, and the bone, right? So off the bat, I'm thinking, geez, what's this patient's underlying condition? What's their frailty? What's their nutritional status like? So the images can really show you a lot. Go through the Shin score, highly unstable. So I took this patient to surgery. This is an intraoperative view. And these are carbon fiber screws. So they're not titanium. And the carbon fiber, I'm going to show you in the next slide what the advantage is. So this is the spinal cord. This is the T11 nerve root here. The T11 nerve root on the right side, I had to sacrifice. You could see a tie on that because you could see on this how involved the tumor was there. And that tumor had actually thinned out the dura so much that there was really no way to preserve that. Drill down the pedicle on both sides, performing that separation surgery, right? Clearing away that bone and tumor away from that front surface of the spinal cord and fecal sac so we can hit it with that high dose radiation afterwards. Again, you can see we keep the bone above, below, screws, carbon fiber rods going across that area. That spinal cord is maximally decompressed, okay? Post-operatively, the benefit of the carbon fiber screws, we can see here, you can barely see them, right? It's like a nice trick we play on the radiologist. It's like, hey, we just did surgery. And they're like, what? No, you didn't. But they're screws there. It's got a thin rim of titanium around the screw, so you sort of make it out here. But the rods are carbon fiber, so you don't actually see them. And this is a lateral X-ray, and you really have to look close to find them. And this is a post-op CT. So you can see here on the post-op CT that you can see there's a tiny titanium shell around the carbon fiber screws. You can see the separation surgery that was done. Here we carved out the posterior wall of that vertebral body enough to separate it. I don't have to take it all out. This patient's got metastatic disease everywhere, right? So that patient's got metastatic disease everywhere. What in the world is the point to take out the entire vertebral body when they've got microscopic disease here, and there? You just got to take away enough, make the radiation oncologist happy. You've taken away the threat that they're going to give too much dose to the spinal cord. And that's the purpose of the separation surgery. Recreate that spinal fluid signal in front of the fecal sac. And this is a cross section. You can see, yes, you can see a little bit of artifact from the carbon fiber screw. That's the screw head. So you can see there's very little artifact there, okay? And why is that important? In the post-operative setting, with traditional titanium screws and screw caps, you can see how on an MRI, you can't even see anything, right? So we already talked about how the radiation oncologists, they're a little nervous. They're not like us, we're going full throttle. They're just like, I can't really see the spinal cord. So in these cases, we end up doing a CT myelogram because we want to see that CSF signal, right? But you're taking that cancer patient, just had surgery, then you're going to bring them back, doing the myelogram and all this. They're not too happy about that. So with the carbon fiber screws, it's nice because this is a post-op MRI with the carbon fiber system. You can see here, it's just a shadow. There's no artifact, okay, around that, okay, especially when you look there, okay? So when we're thinking about spine oncology, yeah, we're playing with different materials. We're thinking about, how do we make it not as invasive? How do we improve the recovery time? How do we select for the best patients? Those are all considerations, but I thought that this would be a good example just to show how this really minimizes the variability in the imaging techniques.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.